All right. Hello, everyone. So thank you for coming to our session today as part of the Stop the Stigma conference hosted by the community and Moxie Educational Services. At Stop the Stigma, we acknowledge the importance of person-first language because language shapes how we understand one another. Person-first language centers humanity over diagnosis or system involvement and reflects our shared commitment to dignity, respect, and equity. We also recognize that individuals may prefer identity-first language, and we encourage speakers and participants to honor personal preference whenever possible. We would like to begin with a land acknowledgement. Although this conference is held virtually, we acknowledge the indigenous peoples whose lands we occupy as we gather, learn, and collaborate. The community is headquartered in Milwaukee, Wisconsin, on the traditional homelands of the Ho-Chunk Nation, the Menominee Nation, and the Potawatomi Nation, with enduring ties to the Ojibwe and Odawa peoples of the Council of the Three Fires. Moxie Educational Services is based in New Hampshire on the ancestral lands of the Abenaki and Pennacook peoples, whose histories, cultures, and sovereignty continue today. Accessibility is a shared responsibility. Thank you for helping create a conference culture rooted in respect, care, and openness. ASL interpreters are provided for each session and captions are activated. So now let's get into this. This is a candid discussion about mental health stigma, diagnosis, survival, and systemic failure inside and beyond incarceration. Panelists may discuss sensitive and personal topics. And this conversation is not only between the panelists, but also with everyone in the audience today. If you have a question for the panelists, a comment, or a response to something someone said, please put it in the chat and we'll get to it as soon as possible. You don't have to wait until the end of the presentation if you have something. So we'll begin with quick introductions. My name is Jonathan Morgan. I am currently a PhD student in criminal justice at the University of Cincinnati and a Dean's Fellow there. Prior to that, I am the founder and executive director of Florida Justice Center, a legal aid organization in Florida, helping people overcome barriers caused by justice system involvement. I am formerly incarcerated and I have lived experience with mental health issues. Divine, can you do an introduction?
Yes. Hello, everyone. Thank you for allowing me to be in community with you all today. My name is Divine Lipscomb. I am a justice and practice scholar, studying clinical counseling, education, and supervision through Penn State's PhD program. Uh, I am the president of Penn State's Justice and Practice Student Organization. I present as a dark-skinned male. I'm currently wearing a white Penn State shirt with a blue logo on it, and my background has our logo for our Justice and Practice Student Org, which is JISO, with a man upheld by some hands and some chain link fences. Blue, purple, and like a sienna orange is the background, and it's pretty much in like a spray paint design.
Thank you. Yeah, I'm sorry, I forgot my visual description. So I am a white male with a beard, a very bald head, and a blue polo shirt. And Stacy?
Thank you. My name is Stacy Burnett. I manage JSTOR Access in Prison. My work is very much informed by my lived history of incarceration. Post-incarceration, I earned an MBA in sustainability, and I use that also to inform my work. I also have a long history of mental health disorders. And I am a white, middle-aged soccer mom looking woman with red hair and very expensive highlights. I'm wearing a white sweater and a red sweatshirt. My background is very characteristically kind of messy. I've got a disorganized bookshelf because I use it often, and I am going to pass it to Victoria.
Thank you, Stacy. Hi, everyone. My name is Victoria Scott. I am the Strategic Initiatives Coordinator for the Educational Justice Institute at MIT, a former inaugural fellow of the Alliance for Higher Education in Prison. And I am presenting as a white woman with brown hair that is in an updo today, hopefully a little bit curly. I have black square framed plastic glasses that I need very much to see. And I am wearing a button down top that is white with accents of blue, yellow, and gray floral patterning. And I have an intersectional identity that occupies neurodivergence in the form of ADHD and high functioning autism spectrum disorder.
Thank you so much for the introductions. That was great. So we're going to jump right into it. So prison obviously is very different from the outside. And one of the things that looks very different as far as I experienced was the way that they treat mental health. So the first question I have is, what does mental health care typically look like inside of prisons, and how is it different from care on the outside? And anyone could jump in.
Well, I guess I'll start. So, in the real world or the free world, however you want to characterize it, there's a community standard of care for um, every everything, whether it's a physical ailment or a mental health related ailment. And my own experience was kind of interesting in that before I went to jail, I was at the county psychiatric center and I went directly from the county psychiatric center to the jail. So out in the community, I received the community standard of care. I go to the jail. It took several months for me to get stabilized. My history is bipolar 2 disorder, for that may be helpful for the audience. Um, so when I went to the county jail, also a county agency, I had the same psychiatrist treating me. So you would think that I would have continuity of care. However, the medications required to stabilize me were not on the jail formulary. So even though I had the same practitioners, essentially the same care team, I was unable to obtain the community standard of care because the drugs weren't on the formulary inside the jail. And that was budgetary. There's also this sense that people who are in jail or in prison are going to engage in drug seeking behavior. And so high risk medications are often unavailable to the population. And then I also lost access to, therapy because you're only entitled to therapy once every 2 months. So when you take away all of the things in your life that provide stability and then switch up medications, switch up the type of care that you're getting, on paper, you may be getting the same thing, but in actuality, the way that manifests, it's not necessarily the community standard of care. And you're also limited to the practitioners that they have. You don't have agency for who you talk to or who's available to you. And you don't get to participate in your care in the same way that you do when you're in the community.
So many good points there, Stacy. And I'd also like to add to what Stacy said, because agency is one of the most salient things that I noticed. If you find difficulty connecting to that clinician or their therapist, you can't just say, I'd like a different one. And you can seek alternative sources for like mental health care. But also, a lot of these clinicians and facilities have caseloads of 100 plus people. They're highly understaffed, so they don't really have the time to be able to allocate to each individual patient in the way that might be needed in that case. They also do a lot of programming in many facilities, which means they have even less time to be able to provide that presence or that assistance and support for somebody seeking mental health help.
So I'm going to take a little different approach to answering this question. And I'm going to preface it with I've been home for 22 years, right? And so I went in as a juvenile. And so I did not have a diagnosis when I went in. And so I didn't have the opportunity or the misfortune to experience carceral clinical treatment. So I wanted to bring in some mental health data to to this, right? And I want to preface it with 37%, according to the Bureau of Justice Statistics, 37% of our incarcerated community members have a diagnosis, right? Whereas the equivalent of outside is 23.1%. So the DLC is not handling what is effectively the same amount of individuals who are on the community side of mental health diagnosis. And that's what's reported. And so we know when you go inside, we also don't report a lot of things because we don't want that stigmatization to also follow us inside because mental health is viewed as a weakness in most male. I'm not sure what female how female facilities look like, but definitely in male facilities. I mean, you don't want to appear weak. And so to have a mental health diagnosis puts you in a different space. We also find that women have a higher number of diagnoses going in. And so when we're thinking about how the carceral system is set up to treat mental health and who has quality access to that agency, autonomy, what medications look like, are you getting the right medications? The DLC is not equipped to take care of this. Because what we see on the outside is most clinicians are burned out, they have heavy caseloads, and they're not equipped to even do it. So how do we expect our carceral systems to do the same?
No, absolutely. And I dropped in the chat a link to a NAMI report that references the BJS statistics that you cited there. And so we're talking about the fact like you don't have the agency to choose your provider, services might be inadequate there. And so it seems like um, people use informal coping strategies, informal support networks, peer support networks. Could you discuss a little bit about what that looks like and how that works in practice?
So, a lot of the time that looks like having our own internal communities where often your peers are more accessible than mental health. You don't have to fill out a slip and wait a week for it to get answered. You don't have to become the problem in order to be seen. And you can just be surrounded by this internal community that you've built with your peers. And I think that a lot of wisdom is shared in those circles. People who have done longer time or have been to prison or jail before often share a lot of their wisdom and coping strategies with people who are struggling and take them under their wings. And for me, I mean, there was a really beautiful moment that I had where I was grieving and being on the autism spectrum, feeling absolutely powerless after my brother had a near fatal motorcycle accident. I was broken. And I was trying to have conversations with prison staff about, like, if I tell you I need 72 in seg, I need 72 in seg because I don't want to destroy everything that I've built in a moment where I lose myself. I need help and support. And there was a woman who I'd known for quite some time that was our walk leader who gathered the girls and had, they all made a card for me. And she pulled me into the bathroom one evening and just let me cry in her arms because I was scared and I felt helpless. And it was that moment that she embraced me where I saw where some of the best support regarding like mental and emotional health in prisons comes from. And that's your neighbor next door in, the cell right down from you, or from the people who build these communities with us on the inside, because they're inside too and they know what it feels like.
It also seems like groups that are like hesitant to mental health treatment or the stigma of it might be more receptive to peer support when it doesn't have that name. And that might be like a way of overcoming those barriers caused by the stigma.
Yeah, Danny in the chat mentioned in the Wisconsin prison system that they have a special unit for people who have a disability so they aren't shunned by other people who are incarcerated. And that's if those units are done well, I think that they can be really incredibly safe spaces for people. I've seen them done not well, where it's a source of like derision and it becomes pejorative if you're in one of those housing units. And there was a time when I really thought I could benefit from some of that structure, but the whole idea of going to ICP, it would make it more challenging for me to get parole. It would make it more challenging for me to interact with the peer network, who Victoria very eloquently stated is often the source of comfort and stability. And I wasn't willing to trade that for like that more structured program, because I would have in my situation, and at that time in prison, that was like 2010. Um, it came with significant consequences if I went into one of those more formal like mental health support units. And it's kind of sad that we have to make those kinds of trade-offs. Like it might have been better for me emotionally and for stability in that moment, but my future self would have been hamstrung by going into a unit like that, because I wouldn't have had programs available to me that I needed to to gain my release.
I was listening to you just now, Stacy, and one of the things that popped up immediately in my mind was how we have to go into these informal spaces, right? Just so that we can protect our access to things that will grant us freedom, right? And so, even in a controlled environment that is supposed to be pushing us towards release, and we are aware of like the surveillance that's going on, and so we have to police ourselves and our own mental health, right, and our own wellness just so that we can get free, right? And it makes me think of like why informal relationships are important, right? And when we think about in counseling, how you create these support groups and you create these spaces where that the therapist just becomes like that sounding board and you let the group itself carry one another, right? Because who knows what's better happening with you than your peers. And so thank you for bringing up like even that internal surveillance that we have to do to our mental health and why those informal networks become so critical to our health and well-being.
So one of the areas that I never hear about in these webinars, and I've attended a bunch, I've participated in a bunch, is talking about neurodivergence. It's always about mental health disorder, but we never hear really about neurodivergence. And so I have two questions. So the first one I want to jump into is like, what does neurodivergence in prison look like? And secondly, how is neurodivergence overlooked and misread as behavioral noncompliance in prison? That is, that the signs, the acting, behavior of being neurodivergent, what that looks like. How is that? How does that lead to people being disciplined, officers misreading it, misdiagnosis by the mental health staff? And so, Victoria, can you start on that?
Sure. Thank you, Jonathan. Well, let me tell you about neurodivergence in prison. it looks like a lot of things, so many things that people aren't trained to look for, so many things that are overlooked or misinterpreted. It can look like almost missing lockup after your second chow because you stayed behind to color code and arrange the chairs that were being put away because it bothered you seeing mixed stacks. It can look like getting very rigid about the schedule and getting upset and not knowing how to function anymore when the institutional schedule reads as one thing on paper and then suddenly it changes in practice. There's an adaptation that you didn't expect, and that throws off not only your day, but potentially your week and possibly ruins your life in the moment. It can look like those moments where you're terribly afraid of losing your security in a moment's notice without anyone giving you a heads up and just having the rug pulled out from under you, like a sudden move of housing units or even cells that nobody took the time to sit you down and just give you 5 minutes to digest that information and say, hey, we need this to happen, and to give you some time to process that information before suddenly it's getting done. And it can look like living with a rigidity and a chronic fear of stimming in public and having them think that you're going to become unruly, that you're violent. It can look like being so worried about having a meltdown that's going to land you in seg and you'll never escape from there afterwards. And the shame that comes with, what will people think of me if I have a meltdown in public, and how am I going to recover from that? Because nobody understands. Everybody sees me one way right now, and they might not accept me after that moment happens to me in front of them. And that is really hard. And as a woman who is on the autism spectrum and has ADHD in prison, I met a lot of adversity when I tried to get ahead of the curve and communicate those things, my needs and understandings, and tried to kind of create that awareness within staff who did not understand. And I was challenged when I first told them, hey, I have autism. And they came back with, you say, as if I was just inventing that. And when I gave them diagnostic paperwork from a state, facility during sentencing, they refused to accept it because it wasn't one of their doctors or experts. And I said, okay, can I have an appointment then to get diagnosed by your expert? Well, we don't have one at present. It's like, okay, so you won't accept an outside diagnosis, yet you don't have anyone on staff qualified to render a diagnosis so that I can receive accommodation or get my needs met. And you're going to treat me like this isn't an aspect of me in my experience here until you receive confirmation with no way to get it. So that was really difficult, and it seemed very illogical to me. I think women struggle in particular because they don't meet a lot of the standardized diagnostic criteria that are written, because a lot of those scientific studies were done on boy children and on men. And that's kind of the traditional template. So presentation in a girl with ADHD might not be being rambunctious. It might be being very flighty or nervous or daydreaming a lot, not paying attention, or talkative, in case you hadn't noticed. And with autism, it can look a lot like an internalized experience instead of having a specific and rigid set of interests. Fortunately for me, being a woman on the autism spectrum, social justice is a big area of interest for us. We do have a very strong moral compass. So I think that kind of worked in my favor in that setting.
Victoria, you mentioned stimming. Could you explain that for people who may not be familiar with the terminology?
Oh, absolutely. In case anybody doesn't know what stimming is repetitive physical activities that allow someone who is neurodivergent to dispel energy, to find a sense of comfort and physical grounding. And it can look like things like finger flicking. It can look like hand wringing. Sometimes it can get a little bit aggressive and include striking or self-tapping, head banging sometimes. It depends on the level of distress and dysregulation as to what that will look like. Some of it is kind of cute stuff, like toe walking, but it also means like my nervous system is very lively right now, and I don't know how to calm that down. I have to get it out somewhere. Yeah, so thank you. That's an excellent question, Stacy.
And so what are there any particular like concrete examples of behavior that people on the autism spectrum might exhibit in prison that would lead to discipline?
Oh
Yep.
my gosh, can I answer this one? Oh, good Lord. I had a very, very good friend. She was, most people wouldn't hang out with her because she was really, people just, they didn't understand her. Um, and she had OCD, she had ADHD, she was on the spectrum. So she had all the things. And prison was not meant for her. So, in the reception dorm at our facility, it was spotless, right? It was phenomenally clean. You move outside of that housing unit on that facility, and it takes a very decided dip in cleanliness. She couldn't handle it. And so the logical thing for her to do with the way her brain worked was to take all of her shower gear and walk in her bathrobe down the because you're supposed to wear your robe going to and from the shower. She decided that her shower was in that housing unit, which was like 4 buildings away. So she walked down the walkway in her robe with her shower caddy in her flip flops because that's what the rules said, and went to this other housing unit. The guards on the walkway didn't know how to stop her, even though she was in her bathrobe. They were not sure what exactly she had intended, but she was very clearly out of place and violated the rule about going into another housing unit that you're not assigned to. She took her shower. She was very happy. She came out. They immediately snapped some cuffs on her because now she had her clothes on, and she's like, I have to go back to my housing unit. They're like, you shouldn't have left your housing unit. And the really sad thing is, she wound up in solitary confinement pre in during the investigation, pre-disciplinary hearing, while they tried to ascertain if this was appropriate acting out for her behavior or for her condition. And they were trying to see if she was using that as an excuse to like pass drugs or to have some sort of touchy feely moment with somebody who might be living in that housing unit. So they automatically defaulted to, this is an excuse that she is using because she wanted to engage in this unapproved activity or behavior. And it took almost a month of her being in solitary for them to decide that actually this was appropriate for her diagnosis. But then they were like, we have to enforce the rules. And they just didn't know what to do with her. But it created quite a brouhaha, and it was very sad to see them penalize her for what her brain said is a natural thing. And how about just keeping your showers clean in all your housing units? No one talked about the lack of hygiene outside of the reception area, and that would have been a great way to support someone who had a condition like hers that could have benefited the entire population if we exercise proper like care and consideration for all of our neighbors.
And we also know, right, from again literature that ASD is underreported, right? There's not even a lot of concrete data to talk about how many people are on the spectrum that are incarcerated, right? Whereas we see a high prevalence of ADHD being reported, about 26%, give or take. And so where there's no surveys that are being conducted by BJS. There, but we know, And I was looking at some global statistics. So, like globally, this also seems to be a problem because there's a study recently done out of London. Yep, 2025, where at least 5% of the population who are arrested have been tested for like, or at least diagnosed with autism spectrum disorder. So, like, we ourselves are behind on some data collection and how that actually looks. And so when you think about treatment and discipline and like what that looks in a carceral setting, it's going to look like defiant behavior and how people approach that. And so, but while we're also talking about like neurodivergence, it's ironic to also understand that when we think about serious mental illnesses, right, and serious psychotic disorders, like those are even classified differently depending on federal, state, and local rules. And so that puts us in a total different ball game on how carceral spaces even address mental health and what serious mental health looks like.
So let's switch gears a little bit, and I want to talk about medication. And so, to what extent does medication become, a substitute for therapy, support, and other forms of treatment for mental health disorder in prison? Um, is medication used as just as a form of control? Is it used for treatment? Do they lessen the amount of, therapy or cognitive behavioral therapy that occurs because they just want to medicate people? Divine, do you have any thoughts on that?
I do actually. Medication, even on the outside, depending on your clinician. I hope there's no psychiatrists on this call. They're gonna hate me. We over we over medicate people in general, right? And so when you think about a carceral setting where again there's a higher prevalence of our community members who are diagnosed, we can't give them access to therapy that's productive. And so you use medication as a way to minimize behavior that is not socially acceptable, right? And so if you can dull a person's senses, you can put them in a transit state where a tranquil state where they are not as active, you get someone who's more docile and easier to control. On the flip side, when we think about how that looks on the community level, when someone is also not or misdiagnosed, like we give them all of this medication instead of looking at ways to help people um, function, right? Because we're talking about functionality, right? We're thinking about a um, when we're thinking about hudas, right? Which is and what impairment looks like in our everyday thing. So can a person tie their shoes? Can a person feed themselves? Can a person hold normal conversation? What does medication um, need? What medications are needed if they are needed to help a person do those things? Um, if we don't need medication or if we don't need five medications, right? If it can be done in one, why are we not doing that? So prisons and clinicians do the same thing, right? They're trying to get people into a space where they can control the behaviors that are not warranted or wanted in society. I start reading the chat about voices and cats and stuff. So yeah, I mean, I think I answered your question. I am not a strong proponent of medication unless it is needed, right? I feel like um recovery is possible, and sometimes recovery means medication, right? Um, a lot of other therapists. I also didn't mention I'm a licensed associate professional counselor. For those like that's why I'm in this realm of like talking about counseling stuff. So like we we need to do a better job because counselors play a huge role in how people are incarcerated and treated while they are incarcerated as well, based on our diagnosis, right? And the way we even give out diagnoses.
Where I was in prison in Florida, uh, it seemed like they were giving out a medication called Tegretol, like candy to people, which would kind of put them in almost a stupor at a certain level. And it seemed like that was a way just to control people and to keep them, sedated and not to cause problems, even more so than it did to treat the condition because the level seemed higher than necessary. Is that something that you all have seen that they're giving a higher level than would therapeutically be needed to get people kind of out of it?
I was amazed by the number of people who were prescribed Thorazine and Trazodone for sleep, because they didn't have any on medications that were on label for sleep. So there were a whole bunch of people, or there was another one that when people, I can't remember the name of it, but you could tell who was on it because they were the ones when they got out of their bunk in the morning, they had like a sticky bun still stuck to their face because it like made you eat a lot. I can't remember what it was, but I 1000% agree with it. When I had mentioned earlier that I was given off formulary medications, um, one of the things that I was given was Librium and it made me hallucinate. And so it became much more challenging to treat me because there were side effects of the medication that were now looking like whole new mental illnesses that I never had before. And it made it so that one of the treatment providers actually said to me, it's not our goal for you to get better. It's our goal to keep you alive until you become the state's problem. The state will sort it out. And so I had never been talked to that way by a practitioner. Like, we know you need something. We're not giving it to you because we're constrained. But hey, if we do our job right, you won't self harm yourself into oblivion, and the state will be able to heal you. That was wild. It also meant that I couldn't really participate in my defense. Like, I was unable to really be present while my future was being decided because I was given these medications that were not appropriate for someone with my condition, but it was the best that they could do with what they had. Um, that's wild to me. Like, if I had fought my case, would I have wound up serving all that time? Um, and and it's kind of unfair when we think about disabilities. It's one thing if somebody has like a cast on their foot or their leg. We can identify it. We give them a handicap sticker for their parking, and we know how to help someone who's walking with crutches. When it's an invisible diagnosis and you look okay, um, and then some crazy stuff comes out of your mouth, it's like, what can we do to temper what's coming out of that reckless mouth of yours? And that's completely different than treating the underlying problem. Like, my brain is a little broken, just like someone's leg could be broken, but because you can't see it, there's no x-ray for it, there's no blood test for it, it's all subjective. Depending on the lens in which people are viewing me or meeting me for the first time, that dictates how much cooperation they give me, how they are going to partner with me as I figure out how to heal this broken piece, or how to live with it. And it kind of comes back to that agency. I had no control over what went into that medication cup. The only agency I had was whether I take the medication in that cup or not. And if I don't take it, I'm non-compliant. That can have other consequences for me if I'm not participating in the prescribed treatment. Um, and so that's a lot to consider when your brain isn't functioning in a way that people think is normal. And we're putting the burden back on people who are the least capable or able to make an informed decision. It's a pretty wild time, like it's yeah, it's and there aren't any easy answers. That would be great if there were, because these systems thrive on conformity. And here you have this thing, you can't give a pill to force that that conformity. Um, and then when you stand out in a prison, you're a target, right? So it's like a self-fulfilling prophecy or loop.
Yeah. And to add to what Stacey was saying and to answer Dr. Terry's question in the chat is there can be very real institutional consequences to either not taking medication or taking medication that they said you needed when that was not in fact what you needed. So you could get a write-up for like administrative burden if you decide not to take your meds and not to go to the med window. You can get a write-up for non-compliance. You could go to segregation because they have now deemed you dangerous and unstable and not medicated, so you are not controlled. Um, and there's also the issue of like medication is not a defense. I was the D board defense attorney, the counsel substitute in my facility for several years. And there was an issue that I was speaking kind of quietly in the background with administration about, which is the psych providers are getting very loose with the script pad here, and they appear to be giving people a lot of test medications for off label use to help out with something they have going on, but they don't tell your officers. They don't tell you because there are like HIPAA issues there. There's no note, and nobody knows that they're dealing with somebody who is in an altered state because they're on a new medication, and no one knows how they're going to adjust to that. But the consequences are theirs and theirs alone, whether or not they were influenced by what someone gave them or they were organically in a moment of crisis. And I think that's not talked about enough, how there's no balance there and how you are effectively punished for treatment that was not optional for you.
So I'd like to change gears again. So we have two related questions in the chat, and I want to get to that. And so the theme of these two questions are, how do we uplift the voices of people who have lived experience, who are incarcerated, have neurodivergence, have mental health challenges, and get administrators to listen to them? I'll add another part to this that, we know that when there's organizing, when people speak up, they risk discipline and adverse reactions from administration. So how do people navigate that? How do they get their voices heard and get policy change within the prison without being disciplined themselves or targeted themselves?
Um, So I'm put on my former politician hat here. You literally, especially when you are in a state facility, most incarcerated community members are still counted in the ballot for, or at least in the numbers of their state representatives. Um, Even if you cannot vote, you should still have access to your state representatives. If you do not, your loved ones do, right? Um, Now the question is that could be me speaking from my position of privilege, where I'm an educated person who knows these things. So like, does the person um who needs a space for advocacy um does their family have that kind of access as well, right? To their state local representatives? Do they have the access to language to even advocate for themselves? And so this becomes an access problem, right? Or access conversation. Um, how do we, as formerly incarcerated community members, also plug into this conversation, especially those of us who have invisible disabilities who can operate in different levels of privilege because it's not seen, right? Um, but yeah, state representatives, right? They have to listen to you. Here in Pennsylvania, um, I realized that at least my last time going inside of a prison, community members were advocating for themselves, and things started to happen immediately because one, I was there as a student, but I also had an elected official hat on, and so they started to move. Um, but what happens when you don't know that an elected official is in a room or that you have access to elected officials? They will do what they want to do when they want to do it. And so I would always advocate to tap into your state reps. And it doesn't matter what side of the aisle you're on. I actually see more people who have conservative values advocating for criminal justice reform than I do on people who are liberal. So yeah, tap into your state officials.
Yes, I second that wholeheartedly. The other uh, thing that I would mention is there are oversight um, boards or orgs in just about every state. And in New York, it was the Correctional Association of New York. I wrote, to use some of my earlier preferred speech, I wrote the blood out of mental health in New York and sent it to every oversight agency I could think of. And because many times these are administrative rules, and administrative rules are a lot easier to change than laws. Laws are more permanent because the administrative rules, if they change, they are subjected to be changed back at the whim of a new administration. So for longevity, yes, legislation is a way to go. Short term, administrative rule change and pressure from those orgs can help. The other thing, this is not a shameless JSTOR plug, but one of the things that uh, I was surprised to learn and to see is how people are using information in the archives that's available to them inside to advocate for themselves. Because sometimes the people enforcing the rules in those facilities or who are rendering the care in those facilities don't know, they're not trained. And when they are confronted with verified information about what they're supposed to be doing or what the community standard is, they're not all monsters. They're doing the best they can in some instances, and they need new information to be able to make better decisions that can improve the quality of life for those of us who have to live inside of those facilities. And so it's a point of pride for me when I see people or when I see usage patterns that suggest that people are gearing up to like advocate for themselves, they're curious about these things, and they can, and it's like the deepest wish in my heart is that they're using what they learn to make things better in the place where they are right now, because they are valued members of a community that might be invisible to the rest of the world, but they are part of a community, and we need to take care of it wherever we are, wherever our community is, finding our people and doing what we can to care for each other. It's just so important. And it really starts with knowledge and information. And then writing the blood out of people.
Um, Thank you for that. Sorry, Victoria. I wanted to jump to another question that we got in the chat, if that's okay. So Latasha put two questions in the chat that are also related. I think they're very important, very timely. As she mentions, we recently lost a member of our community out of California who took his own life after being released for 4 years. And, we know suicidality among formerly incarcerated people in their first year is 24 times higher than the general population. It's even twice as high as veterans, which is an even more talked about population. So, what kind of supports, what kind of changes are needed to increase the mental health successes of people once they get out of prison? How could we ease that transition? How could we support people so that way we don't have as many incidences of people taking their own lives, of struggling after incarceration? What can we as a society do? What can reentry organizations do? Like, how can we change and work to fix this problem?
From my experience, I have found so much support and assistance and camaraderie in the Reentry Sisters education cohort. So they offer direct services such as like basic needs, giving bags of hygiene and clothes and shoes and stuff to women so that they at least have that covered, connect them with resources. And this education cohort provides opportunities for things like financial literacy classes, trauma healing circles, and educational pathways for women who are reentering from prison. And we do a lot of community building together. We got a group chat that is popping off every day. And in the trauma healing circles that we do, we find out that we're not alone in all the things that are haunting us, all the reasons that led us to prison. Every hurt that we suffered, we realized that the other women that were there with us felt like that too when we're in those situations. And there's something so empowering about having those connective experiences of truth and grief and pain and healing with other people who have been on the inside, so that you finally do feel aligned with a community and supported by people, being able to share those experiences, but in a supported environment that offers resources that alleviate that survival panic that you feel coming out, that offer economic support opportunities, that offer chances for upward mobility, that introduce you to positive networks of people who can lend a hand and help you out and lift you up when you're buckling, because it will happen. You know, you can use every moment to your advantage in prison, but the pressure out here is real and we're all human. There are always going to be those times where it hurts and it's confusing and it's difficult. And I think finding peer support networks that are really strong and established is a saving grace, as well as systems of privilege that are engaged in power sharing, who give seats at the table in a non-exploitative and a non-tokenizing way to make sure that people who are formerly incarcerated are getting the assistance and resources that they need.
So I want to jump in here really quick. I'll try to be quick. Um, because one of the things that I find myself talking about often, especially with our community members being released, is that those first few years home are really, really, really trying, right? We are not just trying to escape the statistics of like recidivating, right? We have all of these other communal pressures that are happening. And so Stacy said in the chat, like immediate access to care. We know that most of us enter into the system already being exposed to trauma, right? Most of us do complex trauma, right? We walk in with PTSD and complex PTSD before we even get those diagnoses, right? Some of us, as we also know, about 36% of us walk in with mental health disorders. And so when we are walking back out of those gates, we're not even talking about what happened 11 months, 1 year, 25 years inside, like the trauma that happens from being dehumanized, right? And then you're re-traumatized, being thrown back into society, right? All of these new demands, relearning things. How are you going to feed yourself? How do you continue to build these relationships? And the new beautiful thing that I get to see over my time of being home for 2 decades is like people are now coming home with degrees and they have access to wealth, and like they're re-traumatizing themselves in the name of like advocacy. And it's like, have you seen a therapist lately? Right? Who are you talking to? Right? Who are you building with, like, to release this pressure? Because now you've put more pressure on yourself to speak about your experiences and what you've been through so you can change the system, right? We all do it, right? Especially those of us who are in public spaces, right? When's the last time you gave yourself grace and told yourself it's okay to rest, right? Are you feeding yourself? Are you getting enough sleep, right? Who are you leaning on, right? And so like taking care of ourselves is so important because we're already carrying a world of trauma, right? We're already carrying a world of trauma. And we're trying to make the rest of the world see that they should have some compassion and some humanity about how they see us in the world, right? How are we seeing ourselves in the world? How are we carrying ourselves in this world? our mental health is so important and it's so fragile because we're carrying the world and trauma with us.
Wow. That's just deep. Um, Thank you. So we're almost out of time. I think the last question that I want to get to everyone on is what is, this could just be a short answer because I see Ben's going to be rushing me off the screen here. Um, what's one policy change that you think would make the biggest difference in the outcomes for people who are incarcerated or coming out of incarceration with mental health and or neurodivergence issues?
I think Medicaid coverage for people who are incarcerated would change the playing field. You get a higher caliber of practitioner. You have accountability that you're getting the community standard of care, and you also have offloaded the cost of the medical care delivered from the state budget to the federal government. So there's less incentivizing to control costs by reducing the quality. So I think Medicaid coverage for people who are incarcerated would be the game changer.
For me, I would say enhanced training models for correctional staff. Do the Norway model, train them in social work, in mental health as acuity specialists to be able to recognize who they're dealing with, to be able to tailor their interactions and plans, and to do that in an informed, knowledgeable way that is aware of the diversity and versatility that you're going to be encountering, because that kind of support during your incarceration will really ease the transition out.
Divine, did you have anything?
Um, yes, so policy change for me is I'm an abolitionist, so I believe we should just find a total different way to house individuals who break societal norms, right? How does that look? I guess we still need to build that out.
No, thank you. So I want to take this opportunity to thank everyone in the audience that came here to listen to us today, who engaged in the chat, who wrote questions. It was just an amazing audience. I want to thank Divine, Victoria, and Stacy for sharing their personal experiences, their insight, their expertise. It was just an amazing panel, and I want to thank Ben, Jen, everyone at the community and Moxie Educational Services for giving us this platform and for allowing us to speak our truths. And so thank you, everyone. I think that's it. Ben, did you have something? All right. Well, thank you all very much.